Hello everyone. In this session, we are going to talk about the types of misclassification that can happen when information bias exists. So, as we said in the definition of information bias, this is the second part of problems or the second set of problems that information bias can lead to: differential and non-differential misclassifications. So, what do these terms mean? As the name suggests, differential misclassification means the information bias that is happening is different between different groups. For example, you ask a question differently to one particular group of people and a different variation of that question or a different tone of that question to another group of people. For example, if you're asking about the sexual practices of a study participant, and if you are a male data collector, you would be very comfortable or assumed to be very comfortable when asking these questions to a male participant when compared to a female participant, given the sociocultural context of your particular use case. So when you are asking the same question, when you're asking a similar variable that you are obtaining information on, but you change the way that information is obtained from different groups of people. So if you are doing that, or if your study is experiencing something like that, then we call that type of bias differential bias. But if the information bias is coming equally across the groups, that is, the questions are being asked in an erroneous fashion, but it is erroneous for every group of people. So in that case, we call it non-differential. So these are the two different types of misclassification that can happen: non-differential and differential. Now, why do we worry about these two types of information bias, that is differential or non-differential? It is important because the type of bias, the type of information bias that is coming can affect the result or the estimate, and it affects the direction of the estimate. In general, non-differential bias is safer because you are asking the same type of question, the same error-prone question or the same error-prone instrument is being used across the board for everyone, so it is not causing any differences in the way we measure in different groups, and we will see why it is safer. So the direction of bias or the way in which this information bias can act is of two types. One is towards the null. So the estimate or the result comes towards the null. Null value means there is no difference between the two groups or the treatment is not effective. So that is the null value. In relative risk or odds ratio, that null value is 1. In risk difference, the null value is 0. So if there is a misclassification happening, the results can either move towards the null, that is, the results might become non-significant, or it may move away from the null. Away from the null means the results are magnified or enhanced in some way compared to the actual truth. So the first one, towards the null, refers to the result being nullified or the effect being minimized in some way, whereas away from the null means that the result is amplified or enhanced in some way in both directions. That is, the result might be above 1 in case of relative risk or odds ratio, or it might be below 1, and it might be above 0 or below 0 in the case of risk difference. So these are the two types of effects that we are worried about when there is a differential or non-differential misclassification. And we will see in which type of misclassification what is the direction of bias. In simple situations, as described below, the direction of information bias is generally towards the null. What are these simple situations? When you having an exposure or disease which is dichotomous in nature. So for example, smoking present absent, which is a dichotomous exposure variable; lung cancer present absent, which is a dichotomous outcome variable or disease variable. And the second situation is where the instrument or the questionnaire that you are using or the test that you are using has relatively high sensitivity and high specificity, that is greater than 0.5. A non-differential misclassification might happen when classifying the patients into or the participants into either diseased or non-diseased, and in situations where error in one variable is independent of errors in the other variables. So the data collector might be very good or well trained in capturing one set of variables, but he or she does not have that level of sincerity or that level of training to capture errors in other variables. So errors in one variable are independent of errors in other variables. If this is the situation, then the direction of information bias is generally towards the null. So sometimes, apart from the main variables, that is the exposure and the outcome variables, there might be errors happening in the covariables or the covariates, or those third variables which are relevant to explaining the association between exposure and outcome. So sometimes it is always important to control for these third group of variables, which will help us to understand the association better between exposure and outcome. If there are errors in the measurement of covariables or covariates, it will hamper the efforts to control them. So for example, if there is an association between exposure and disease, and if say age is an important confounder that needs to be adjusted for the true association between the exposure and outcome to be established, and if you make a critical error in the measurement of this age, then we are limited in the way in which we can handle this variable for controlling. And the direction of bias in this case is generally unpredictable because we don't know how accurate or how well or how error prone is the age variable. You might be better at capturing age for one group of people as compared to the other group of people. You might be better at capturing age for women as compared to age for men. So there might be numerous ways in which errors can creep into the measurement of this particular variable, and therefore the direction of bias is generally unpredictable. This is the case when there are errors in measurement of covariates or covariables. So let us look at a real-life example of a randomized controlled trial of self-help methods for quitting smoking. So there are some self-help methods which help people who are smokers to quit. So the primary outcome of such a study, of such a randomized controlled trial, will be self-reported quitting rates. So you ask the people whether you have quit or not, and they are likely to give you an answer like, say, yes, I have quit, or no, I have not quit. So you can ask a question as follows. In the past 7 days, have you smoked a cigarette, even a puff? So this answer can be validated by a laboratory measure, say salivary cotinine values. And people who are unwilling to schedule an appointment for this particular test may have very high quit rates. So this is an example of how measurement of covariates or measurement of the outcome variables or the exposure variables can lead to errors, because that group of people who had very high quit rates did not want to schedule an appointment. Do you know why? So those people who know that their answers will be verified by this biochemical test or this laboratory test do not want to schedule an appointment, because you will find out that they had not said the truth or they have not been truthful when they answered your question. So this is an example of how we can identify the existence or the possibility of a bias or information bias happening. So in a typical 2x2 table where A, B, C, D represent the different combinations of exposure and disease, we can predict what type of bias is likely to exist and how it is going to affect our results. If the study participants are selected on the basis of outcome and the exposure is not independently measured among cases and controls, then if there is a higher frequency of exposure among cases, that is the cell A, then it can lead to information bias. So let us look at an example of case control study and a cohort study where we are collecting information about exposure and outcome respectively. So what are the sources of information bias that can happen in a case control study? If you are collecting information from a case or a control leaning towards a specific exposure status, that is, you know that a particular person is a case that is affected by the disease, and you try to extract more specific information about exposure from that person, and you casually ask the same question from a person who is a control. So this kind of differential seeking of information between cases and controls is an example of a source of information bias. Similarly, in a cohort study, you are going to collect information about outcomes. And if you know which persons are exposed and which group of persons are non-exposed, you are likely to make more passionate effort to identify outcome in those who have the exposure, whereas you are likely to have a casual attitude towards those persons who do not have an exposure. So if again this is existing in a particular cohort study, then it is likely to lead to information bias. Let us see one by one. In a case control study, study participants are selected on the basis of outcome, right? You have cases who are affected by the particular disease, and you have controls who are free from that particular disease. And you are going to measure the exposure status of cases and controls. But here lies the problem. You are going to assess the frequency of exposure. How many people are exposed among cases and how many people are exposed among controls. If there is some premonition, or if you have some presumption or some prejudice that makes you assess a higher frequency of exposure among cases. So here, as denoted in the 2x2 table, the cell A, it is written in capital, which means you have gone the extra bit of length to gather more information on exposure among cases. So here, the cell A is amplified. If you are doing the same thing among controls, that is, you are going to ask for more information, you are keeping on digging, you are not letting the control go, that he or she has to give you a positive exposure history, then here the cell B is amplified. So a measurement of higher frequency of exposure among cases leads to an inflated cell A, whereas measurement of a higher frequency of exposure among controls leads to an inflated cell B. Measurement of a lower frequency of exposure also can lead to information bias. As you can see see here, if you are not very interested in the frequency of exposure among cases, this must be a protective factor, right? Like vaccination or physical activity or healthy diet. So here you are not interested in the case being exposed. So here you are going to measure a lower frequency of exposure. So that will lead to an inflation of cell C, whereas you might do the same thing for controls, in which case the cell D is inflated. So depending upon how you are collecting information from controls and cases on the measurement of exposure, you can have these various combinations of inflated cells, and depending upon which cell is magnified or which cell is inflated, your relative risk or your odds ratio will move in that particular direction. Similarly, in a cohort study, you can have the same kind of effects. So in a cohort study, study participants are selected on the basis of exposure, exposed and unexposed, and the outcome is not independently measured among the exposed and unexposed groups. So there is some relationship in the way you measure exposure outcome among these two groups. Again, if there is a higher incidence of outcome that you are measuring among exposed, cell A is inflated. If you are doing the same among unexposed people, cell C is inflated. If you are measuring a lower incidence of outcome among the exposed, cell B is inflated. And if you are measuring a lower incidence of outcome among the unexposed, cell D is inflated. So these are the differential effects that can happen. Just to tell you how this information bias actually looks like when the data comes to you. So the 2x2 table makes it clear that these are the different ways in which your information might get affected. This is a flowchart that you must have already seen during the selection bias lectures. Here you can see that up to a point selection biases operate, and beyond a point information biases operate. So up to the point of selection of participants into the study, selection biases operate. Once the study participants have been included in your study and you are beginning to collect information about either exposure or the outcome, then the information biases come into play. And just to summarize what we have seen so far, information bias can happen in descriptive studies as well as analytical studies. In descriptive studies, again, information bias can be random or systematic. If there is a random error in measurement, that is, your instrument is randomly performing poorly, irrespective of who the person is, then there will be no particular bias, but there will be a loss of precision in your overall results. Let us assume a weighing machine which gives random errors during measurement. Sometimes it gives more value, sometimes it gives lesser value, sometimes it gives accurate value. So if that is the case, then that instrument will not lead to a bias in one particular direction, but the overall precision, the overall accuracy in the results will be affected. So that is a random information bias. If there is a systematic information bias in a descriptive study, let's say the same weighing machine consistently gives 5 kilograms more than the actual value, then that information is biased towards a higher value. So we call that a biased result. In analytical studies where there are two group comparisons or more than two group comparisons, we saw that particular misclassification can lead to either non-differential bias or differential bias. Non-differential bias means error in measurement is uniform in all groups. So irrespective of whether it is a case or a control or an exposed or an unexposed person, the error is going to happen. So in that case, the error may be random or systematic and the bias will be towards the null. If you are going to introduce differential misclassification or differential error in the measurement of exposure or outcome in different groups, then again there may be random or systematic error, and this is going to lead to a bias towards or away from the null because the direction of bias cannot be predicted in a differential situation. Now, let us look some of the ways in which we can anticipate biases and try to write a protocol or try to think about biases when we write a protocol and see how to reduce information bias. So the first question that you will ask is the sample representative, which is obviously a question to prevent selection bias. Coming to things that are relevant and specific to information bias, we ask ourselves, are the exposure and outcome criteria standardized? So is there an operational definition or a universally accepted definition that you are going to follow in your study? For example, if you want to classify a person as having CKD stage 1, 2, 3, 4 or 5, you need to follow some standardized formula, standardized definitions for chronic kidney disease. Are they specific enough? Are they clear enough? Are they well measured? And are they applied consistently by the data collectors or trained field workers? So if you match these criteria, or if you meet this criteria when writing a protocol and then final execution, you are likely to reduce your chances of information bias. Then you ask yourself, could the exposure status of a person affect the probability to detect an outcome? So it should not be so. That is, the exposure status should not affect our sensitivity or our ability to detect the outcome. It should be the same regardless of whether the person is exposed or outcome. So the same instrument with the same sensitivity, the same specificity, the same kind of questioning technique should be used for both exposed as well as unexposed people. And the other way around is, could the outcome status affect the probability to recall the exposure? Whether a person is affected or not, does it affect their ability to recall the exposure? A typical example here is a mother who has a child who has some disability will keep on thinking about what happened during pregnancy so that this particular child has been affected. Whereas a mother who has a normal child without any disabilities will not have that motivation to keep thinking about her pregnancy. So these two groups of people, mother with a disabled child and a mother with a normal child, will have a different recall for their exposure. So if you are thinking that this is the case, then probably you have to design something or ask your questions in such a way, or probably make it record based, to see that the probability to recall the exposure is our ability to detect the exposure or measure the exposure is equal between these two groups. And with this, we can prevent majority of the information biases creeping into our study. Thank you.